One is a flat plane appliance that covers all the teeth,
Like this.
that builds in an anterior guidance into the system.
Mhm.
And the
Can you just,
other
can
one,
you just, can you just describe anterior guidance?
yeah, anterior guidance means, and this is what in dentistry, why why we know that cross bites need to be corrected and anterior open bites aren't the best,
Mhm.
is that anterior guidance is when you have your front teeth are meant to be protect your back teeth in lateral and protrusive movements. So your canines are the longest rooted teeth in your mouth, and they kind of create like the barriers or walls, if you will.
Mhm.
And they also have a built-in ramp. And we like in dentistry, we like that ramp to be a shallow ramp, not a steep ramp. And so we like to see a shallow guidance, meaning that when you slide your jaw to the right or to the left, that canine is going to lift your back teeth apart.
Okay.
And as you continue to travel on that canine, the shallowness of that is a nice shallow ramp. So you're not pushing up a hill. It's a nice glide across onto your front teeth. We
What would
call
a
it
what would a what would a non-shallow ramp
a
imply?
non-shallow ramp would be like a almost like a class two occlusion with or a very deep bite.
So their front teeth are coming. I'm sorry, they're
Where you're locked, yeah, where your mandible's locked in place.
okay. So their
So
top is it because sometimes I'll see top teeth, the top teeth that come really far down in front of the bottom teeth, and I
that
never know
would be
whether that's a good thing or not.
right. That's kind of where the mandible's trapped,
Okay.
and that can be from a genetic component when a person is growing, and it can impede the growth of the mandible, so
Okay.
it's blocking it back. That would be like a tight,
Yeah.
steep guidance. So
Okay.
there's like no room for that.
Is that what you're talking about as like a
Yeah, and then the same thing happened on your cusp. Is be very is you just can't really quite get there, and you're sort of locked in, almost being in a room where the walls are super
Mm.
closed in.
Yeah.
And,
You're gonna lack mandibular freedom.
and a lot of times you'll see a lot of times those patients will have very high vaulted palates, very narrow
Okay.
uh, uh, maxillas and mandibles.
Right. So when a PRI therapist thinks that an individual or has determined that they think this person is going to need dental intervention, usually one of these people may have a missing tooth, a molar that's been pulled. They may have had teeth pulled to begin with. They may have cross bites, open bites. So you tend to make a
You're
flat,
right.
the
So
flat
a
planes.
flat appliance, yeah. And then there's another appliance really quickly where it doesn't necessarily have the anterior guidance. It's more to give the patient an immediate posterior occlusion.
Okay.
A lot of times, and there are specific reasons where you use one or the other.
And do you know what those are? I know, because having spoken to you, I know you prefer the splints with anterior guidance, I believe.
Well, I don't say that I prefer them, but I have learned because I've got a lot of great mentors in the PRI world, and I've gone to PRI courses, and I've learned. I mean, I've learned that sometimes doing the other type of appliance is necessary, and especially when there's a lot of issues with tongue, posturing,
Mhm.
a lot of times that anterior, and even when I make those appliances now, I really work hard at making sure I've got room for the tongue to be where it needs to be.
So
Um,
you're talking about the splint without the anterior guidance?
both.
Oh, okay, okay.
Well, even with the splint you have, I work very hard not to make this so big in the front. You
Okay.
know, I really work hard at minimalizing that.
And
And
why do we want to keep, because I know that was always the recommendation in PRI is to keep it
yeah,
as thin as possible, but still to maintain structural integrity.
yeah.
And do you know why that is?
I think it's to get that tongue to to behave basically. I mean, I'm not a PRI PT, so I can't speak to a lot of it. I'll have the therapist that I'm working with that'll say, I would like for you to make me for this patient an MOO, which is the one that has the a lingual bar.
Mhm.
and just the posterior contacts.
Mhm.
Usually those patients don't necessarily have a TMJ issue,
Mhm.
but they definitely have an issue where they, have a lot of issues with, their tongue being a driver, and we're trying to calm that down.
Right.
And so I find that is helps to tone them down
Okay.
to kind of, uh, help with that issue. And then the patients, for sure, if there's a TMJ issue or a pops or clicks or adaptation of the joint, then we tend to make more the full coverage
Like this.
flat, correct,
Right.
but
And
minimizing the bulk in the front. So also, because the tongue is a very big muscle and
mhm.
it affects the hyoids, it affects breathing,
It
how
really, it's
efficient
really part of your neck. I mean, it's just,
part of your neck.
it's part of your
And
neck.
so,
And that's the big deal from a PRI perspective
yeah,
is
when I
tongue is
first
good,
started,
neck tension.
yeah, I was making them and making sure I had my guide. I was being a dentist,
Yeah.
but doing what I was taught to do. But then because I'd listened and I wanted to learn, I was, shown that maybe I needed to reduce that and
Mhm.
make it different, that would be a better for the patient,
Mhm.
better for their overall treatment and therapy.
Mhm.
Anyway, so those two appliances are the ones that I make, and I think I make more the flat plane full coverage more than I do the other. But when I've done the other, it's worked,
Right.
and it's usually been the therapist that asked me, "This is
Mhm.
what I'd like you to make."
Okay.
So I don't make that call.
Right. Okay.
Um,
Okay.
the therapist usually makes that call, and we discuss it, and I'll ask, well, why, and they'll explain to me, and then we'll do it, and
Now that you've been exposed to PRI, you know that someone might need one of these, not for
yeah,
TMJ, not for, they don't have any issue with their jaw in the sense that they don't have jaw pain.
yeah,
They might
yes,
have hip pain that will not clear up.
yeah,
And it's weird for, I just take it so for granted now because I've been doing this for so long, and it's just like, yeah, obviously this is what needs to happen. But I realize also I have to put my mind back 15 years ago before I found PRI. I'd probably be pretty kind of puzzled by if someone said, "Oh, you need one of these for your back pain." What is the connection? And just now, anyone who watches my channel is going to know about PRI anyway. But why, from a postural restoration perspective, as a therapist, we need this neck to be relaxed. If the neck cannot relax, you can do every pelvis, hamstring technique, glute technique, every PRI technique in the book for hamstrings, adductors, side lying, doesn't matter. If the neck cannot relax, it's all going to have it's never going to have the effect that it needs to have because the tension in the neck holds you into extension. So if
yeah,
these SCMs or scalenes or upper traps remain overactive, they keep you up in extension, they keep you neck breathing. And if you can't stop that neck breathing because you're stuck in extension, you can't do these things. You can't do these techniques because the neck is ungrounding you. It's just pulling you up constantly. So if that situation occurs and we take tongue depressors and we change someone's bite just by putting it between their teeth, and I've shown videos of this, and all of a sudden they have these full ranges of motion that they didn't have before and they can breathe. And that's when we kind of have the idea that they're going to need something like this, not for TMJ issues, TMD issues, but to allow, I guess it would be two things which are completely related. People will overuse their stomatognathing system, so their jaw and associated muscles, for stability when their bodies become unstable. And when that happens, the jaw loses its freedom to move intrusive movements. And if the jaw can't move from side to side, like you were talking about, like if you can't get a canine to disclude the posterior mouth, if you can't get that shifting, the neck cannot side bend and rotate effectively, which means everything down low is not going to side bend. You're not going to have frontal plane movement of your rib cage and your pelvis and your legs and everything else. So when this is locked, when the jaw is locked up, the neck gets locked up, your head gets locked up in a posterior rotation quite often. You don't have freedom to move your head, and that is very concerning to the brain. Those are all cranial nerves. That's a vagus issue. The vagus nerve innervates, part of the vagal system is that accessory nerve that innervates the SCMs and the upper traps. So if those SCMs and upper traps are dysfunctional, that's going directly into the vagus system. And it's high alert when that's occurring. So these are needed to inhibit, turn off that improper stabilization and improper use of that jaw and tongue and associated musculature, right? So that's what they will come to you for. But you'll often find open bites and cross bites that are causing this neck to be tense. So just give an overview of the process, of how the process would work if the PRI therapist says, this person needs a splint.
Yeah, so basically what I do, there's a lot of different ways to make a splint. I think the most important things are that we make the splint on the lower arch because we don't want to trap the cranium. When you have a appliance on the upper arch, you basically don't allow for cranial movement and changes. So that's why we make it on the lower.
Now, to a lot of people,
yeah.
Is it commonly acknowledged at this point within dentistry that these bones of the cranium have movement?
I think it is, yes.
Right,
I think
good.
that we now, I mean, we're in dentistry, I think we can say that there's probably some small movements of the cranium. That I think we're open to that. I think I want to say that yes, that's true.
Okay.
Especially with the course that I just took at this one institution, well-known institution, that I think that was brought up as a truism.
Okay, good.
So that's I would say yes to that.
We've come a long way.
Yeah, but that just still doesn't stop dentists from making them on top.
Right.
A lot. But I was one of those dentists who would make them on the bottom as much as I could. And not because I was thinking about the cranium, because that's kind of how I was trained to make them.
Okay.
But then I would sometimes make them on the top, So anyway, so that is number one. So the patient knows they're going to get an appliance made on the bottom. Now, I make mine, I think there's a lot of ways to make them. And the way that I do it, I take good old-fashioned impressions. Now there's scanning. There's, controversy about scanning and accuracy, and I think they're coming a long way. I think
impressions are where you put the
mold,
the goo, and you press them down. You have to hold them there. Right?
Yeah. So there's scanning. There is then I do take what's called a face bow, which is a device that allows me to get the position of the maxilla in space. So is a maxilla tip this way, this way, this way, in 3 dimensions. Because what I do is I take that and those models, then I also take a bite record. And what's important in that bite record is you'd like your patient to be in their most neutral position in capturing that bite. And so in dentistry, a lot of times we would look to CR, central correlation, but a lot of times what we'll do is, and I've seen this, I think I've seen Ron do this on videos where he's actually manipulated the patient to get them in the most neutral position, and then the bite was captured.
So he'll literally be holding their head in his hands, putting him into a state of neutrality that they can't get on their own.
Correct.
So that you can make the impressions on a neutral.
Yeah, and that would be for the bite record most importantly, because this way when you build the splint, you're building.
What is a bite record?
A bite record is the position of where your teeth meet, where they touch. So when you're in neutrality, your bite might touch in a different place when you're not in neutrality.
And that's why we want to get people neutral
Correct.
as much as some people you can't get neutral, but
So, right.
as much as possible, you want to get them neutral before you go through that process.
Yeah. So that's kind of what we try to achieve.
Okay.
So those would be important things. And then in the making of it, I make my own, I'm in the lab and I'm making my acrylic, and, it's kind of very old school method. A lot of people will send it to a lab and get an appliance back, and that's fine too. I mean, that works. So I think the most important thing is that it's made on the lower, and that you make it as streamlined as possible. You make room for the tongue. And when we deliver that appliance, and here's a paradigm shift in dentistry, and here's why I kind of sometimes get raised eyebrows, is where I deliver my appliance, I deliver it in standing.
Standing, right.
The patient is standing in front of me, and I have the marking paper between their teeth, and they're we're looking for balanced occlusion from the back molars to the cuspids.
And cuspids are, what are cuspids?
The canines.
Okay. So
And
canines and cuspids are the same thing.
Yeah.
Okay.
And
The bicuspids are like premolars?
premolars. Yeah. Yeah, correct. And then we're looking for lateral movement to be shallow, to the good guidance, the disclusion of the posterior teeth.
So we can be assured that a head and neck can rotate and side bend and do all these things.
And their hips can move.
Yeah.
I mean, all of those things kind of come into play and loosen up when the mandible begins to loosen up.
Absolutely.
So as the patient begins that movement, sometimes they can't move very much at the beginning.
Yeah.
But by the time I
was one of them.
Yeah. Then we get people.
I couldn't, yeah, and you're like
really going.
Yeah. And you said, "Oh, we're going to get it to move," and it did. It did.
And then the other most important thing that's a little bit difficult in dentistry or for dentists, I think, is that you may see, we look for these marks on our appliances, dots and dashes, which we call. And what happens is that we may see equal pressure dots and nice dashes, but the patient may not feel those dots that we see. And so,
which is a really strange thing until you've been doing this long enough where you just take it for granted. Right. But it's like, how do you not feel that? Your teeth are clearly touching.
Right. And so you have to ask the patient, the dialogue, do you feel that? Mm-hmm. And even if you see it and they don't feel it, they don't feel it.
Their brain is not registering that it exists.
For adjustment until they feel it.
Mm.
And that is a difficult thing, because for the dentist, if you see it, the patient's not feeling it, you're thinking, well, I know I've got it because I could see it.
Yeah.
We're all about seeing is believing.
Yeah.
And you have to trust that patient's brain and nervous system have not gotten there yet.
And that's the thing. Their brain, their nervous system, not what you're seeing, what they're sensing is completely, I mean, again, once you've done this long enough, and you see things where people think they're standing on their left leg and their upper body's completely over on the right side and they have no clue. And I've shown videos of this as well. But when I got this one, what I had no sense of was my left canines.
That's right.
I remember touching that, and what am I touching? And you're like, those are the canines. I just, because I was in a faulty position and I never had anterior guidance, unfortunately, for my 2 previous splints, and it has made a difference. And along with changes I made to my visual system on my own, because I know that you can order your own glasses on 2 different websites without providing prescriptions. So I think I was being held hostage by my astigmatism correction.
Yeah.
It was tightening me up, and every optometrist said, "Well, this is what gives you 20/20," and it was never felt right to me. And contacts don't feel right to me, and so I just go just spherical correction, and that's it. Right. And that works so much better for me. So it's these weird things that no one would think of.
Yeah, I mean, it's like
happens, but I had no awareness of those left canines
Yeah.
because of the pattern that I was in for, even though they clearly touched, but I couldn't sense them.
And sometimes
Now I do.
in that appointment, I might stop and just have the person walk up and down the hallway a couple of times, and then have them reconnect,
Yeah,
just to kind of get things moving. And
yeah,
or if they're wearing glasses, I'll say, well, take your glasses off now. I want you to touch, and
mhm,
why, and especially if they, you'll be amazed by just taking glasses off and how that will change the occlusion. And if they're wearing
yeah,
the wrong types of shoes, like I had a patient who was a power lifter who brought in her powerlifting shoes,
of course.
and she wanted her splint to work with her powerlifting shoes so she could have better range of motion. But when she put her sandals on,
Uh,
changed her bite on her
yeah,
splint.
yeah, yeah,
And so you have to listen to the patient. You have to take into account all these other factors, because in dentistry, when we deliver splints, we deliver them lying in a chair.
right.
And so for me, and I just think, just if there's any dentists listening out there, I would just say, be open to trying it in a different way. You're still delivering the appliance. Be open to the standing piece, and I think you'll be amazed at what you might or might not find.